hop on and join us. And I'm going to make housekeeping announcements because Wendy likes it when I do that. It makes her job a little bit easier. Welcome everybody that's joined on. I am Natalie Teeter. I am the president for CMSA for this year. Just a little bit about me. I work with Hanger Clinic, so orthotics and prosthetics, and I'm a business development manager. And so I joined CMSA. I make everybody else say how long they've been part of CMSA, and I don't think I have. So probably maybe 5 or 6 years ago. So I just, big believer in education of our patients, education of our community, education of our referral sources. So CMSA is a great joint venture for me just because that is CMSA's passion, education for our case managers, our professional case managers. So we just appreciate you guys joining us. Quick little housekeeping announcements. So at the conclusion of the webinar, you guys will get an email that contains your eval, your course eval, right, Wendy?
Yes.
Yeah, and that's what you need to fill out so that you can get your certificate from us. So just be on the lookout. If you don't get it in the next few days, you might check your junk folder. But you can always reach out to Wendy if you need help with that as well. We are going to be taking questions, and so we will be utilizing the chat feature. So for those of you on iPads or anything like that, if you'll just click your screen and click the 3 dots that say more, that's the chat feature. You should be able to see it on your computer as well. You can click on the chat feature. Feel free to ask your questions anytime throughout. It will not interrupt the presentation. What we'll do is at the conclusion of it, we'll have some time for some Q&As. And so we'll kind of ask at that time. So we can kind of move forward and do it that way. Just a few quick announcements. For those of you looking for some more CEs, which I know you are, go ahead and write down, save the date for April 8th. It's going to be a great continuing education with Ryan McFarland. He is the Assistant Chief Financial Officer, and it is going to be on pediatric neurological rehabilitation. So registration for that will actually start on March 15th. And so just so you don't have to remember a link or anything, you can always seek us out on our CMSA-OK.org website and click on our webinar opportunities, and that will take you to the link that you need to register for the webinar. And just a friendly reminder, it is free for our CMSA members, and for our non-CMSA members, if you're a first-time attendee, you can attend for free. And then after that, it's $20 for each of our webinars. And I am going to take just a quick minute and introduce our board. So let me get on here and see who is all on here. It looks like Janet is on mute. Janet, do you want to unmute yourself and introduce yourself, dear? Let's see. I thought I'd kind of give her a second to unmute if she can. And board, you guys might go ahead and unmute yourselves so that you can introduce yourself. Janet might not be able to unmute just quite yet. Let's see here. How about Miss Sharita? Sharita, can you unmute yourself and introduce yourself, dear? Anybody? Correct?
Yes, Sharita.
Oh, I hear you, Sharita. Are you there?
We've lost volume.
Who's lost volume? I can hear you, Sharita. Oh, I lost Sharita. How about Kurt? Kurt, would you like to introduce yourself?
Yes, Kurt Ederer. Can you hear me?
Yes, sir, I can.
Oh, hot dog, believe it or not.
I love
it's going through. No, I've been a CMSA member for 25 years. I've been a board member for a couple of years now. I'm a certified case manager, do work comp medical management. And I've done that for 25 years. Worked for Integris for 27 years. And enjoy being on the board for sure. It's a great thing to do. We need to get more members.
Yeah, we enjoy you too, Kurt. Sharita, I'm going to try and come back to you one more time. I didn't know if you might be able to hear me now. And that's okay if we can't. But we're just going to go ahead and jump forward to Maria. Maria is with Select PT. She's part of our board. I'll let her introduce, but we are fortunate enough to have them as our sponsors today. So Maria, I will give you just a second to share your screen.
Okay.
And we'll just kind of let you take it away, dear.
Hey. So sorry, let me get all this going. I'm Maria. I think you guys can mostly see me, but I'm the business development manager with Select Physical Therapy. Let me get this going for you. Okay. So like I said, I'm Maria with Select PT. We are a national physical therapy company, but in Oklahoma, we now have 27 locations, including, if you include our MAPS location off Rockwell, that's 28. It's a satellite location of one of our other ones. But we did open 2 new ones this summer. In spite of COVID, in spite of pandemic, we were really excited to expand. We opened on the first floor of the Total Healthcare Partners building off of 39th and the Turnpike. We also opened in Jinx. And in all of those clinics, our services obviously include physical therapy. 10 of those include certified hand therapy. And we also do an in-home program for those patients, you know, recovering from surgery. If they are just live alone and they're still on pain meds, it's a really good option because, you know, they're not driving, they may not have someone else living with them, but it's only PT. And it is coded as outpatient physical therapy. We are not home health. We don't do any nursing, but it's solely outpatient PT, but done in the home. So it's a good option for surgery, a lot of total knee, total joints that we've seen the most of for that. Another thing I like to reiterate is we do only hire licensed physical therapists at Select PT. We don't hire techs or aides. So that means that everybody that's treating your patients is licensed, as sat for a board, takes a yearly exam to re-up their license, and does continuing ed credits, much like you guys. The other program that we've just started that we're really excited about is our recovery and reconditioning program. We introduced this because of COVID, but it does help with patients recovering from influenza and RSD, and it treats the whole body: neurological issues, musculoskeletal, pain and soreness, dizziness and vertigo, cardiac impairments, stability impairments, weakness, and just general fatigue. So much like those patients, or all of those patients that are testing negative now, but still have just some deficiency after COVID or a bad flu or a bad RSD, to get back to conditioning and back to their way of life. It's a really awesome program. I have personal friends and family that have gone through it, and they say it's made all the difference. So I don't have a flyer on that yet. I'm working on one with our corporate. So I emailed one to Wendy. I'm going to email you a new one, actually, Wendy, pretty soon.
Okay, great.
And also, so what I'm most excited and why we're glad to be a sponsor today is we have done in women's health here in Oklahoma City now for years. And I'll introduce Lynn and Aaliyah here in a minute, but we are expanding that program. I know there's some people that are doing all pelvic health across the board, men and women, but right now it's just women's health. So I'm going to introduce Lynn here really quickly on the next slide. This is Lynn Smith. She graduated from the University of Oklahoma in '98 and received her doctorate of PT from Arcadia in 2014. She completed her pelvic floor training in Minneapolis under Megan Smith, I'm going to butcher this, Canistracki, and has 22 years of experience treating women's health, including pelvic pain, urinary incontinence, urge frequency and stress, fecal incontinence, organ prolapse, and OB-related low back pain. So she's been with Select at our clinic at Rockwell and Expressway now for how many years? Since '98. So, or no, she graduated in '98. Lynn, when did you join Select PT? Are you there, Lynn? I think she might be muted, but she's been at that Rockwell and Expressway clinic for a long time. Also at the clinic is Aaliyah Young. She graduated from OU in 2011 and received her doctorate of PT also from OU in 2015. She was select 6 years and enjoys patients of all kinds and is taking the pelvic floor level 1 course from Herman and Wallace very soon. She was enrolled in it and they put it on the back burner since COVID. So when they get a new date, Aaliyah is going to sit for that and be able to treat patients as well as learn from Lynn, who she's treating in the same clinic right now. So those are our 2 right now. But like I said, we are growing the program. We want to add more clinicians to that program that are going to be doing women's health, some men, but right now it's mostly just women's health for the pelvic rehab. And here's a little bit about our services for pelvic rehab. I'm going to email this to you as well, Wendy, so you can email it out. I know you can email this PowerPoint out, but kind of goes over all of the conditions that are benefited from physical therapy. Dr. Barenberg, I'm sure will touch on a lot of these and a lot of things that physical therapy help. So the address is at the bottom. That 7000 Northwest Expressway is where Lynn and Aaliyah are treating right now. But like I keep mentioning, it's going to be growing. So I will let you know when more clinics come on that. Questions or comments about that or about Select PT? I've included the clinic phone number where Lynn and Aaliyah treat, their emails, my email, the address where they treat, and then just the Select Physical Therapy website. So I'm really excited to be sponsoring this. I'm really excited for this program to grow. I know PT can do huge things for this kind of diagnoses. So we are excited to be part of CMSA as well. And this is my 2nd year on the board. But that's all I have for right now. You guys hear me?
Yeah, sorry.
Yes.
I was going to say that they did set the date for May 1st for the class to
Oh, great.
start. Yeah.
Okay, so Leah will complete that she'll start that May 1st. So as that's completed, I'll add her to our Rolodex of clinicians that are doing this. So thank you, Aaliyah.
Perfect. Thank you guys so much for sponsoring again. We're just super excited to be able to do this. I'm going to go ahead and get us kicked off and get us started. So I am going to read a quick little bio for Dr. Barenberg. He is a board certified and fellowship trained urogynecologist. So
yeah, it's a big word.
yeah, I was like, I probably should have read this a few minutes ago before I got kicked into this, but it is a fairly new subspecialty that focuses on disorders of the female pelvic floor. Pelvic floor disorders can be the result of weakened or damaged pelvic floor muscles secondary to childbirth, obesity, surgery, chronic disease, or heavy lifting. Dr. Barenberg sees women affected by pelvic floor disorders such as urinary incontinence and pelvic floor organ prolapse. He also sees women in need of specialized care to correct previous vaginal mesh complications, fecal incontinence, pelvic or vaginal pain, blood in the urine, recurrent urinary tract infections, and difficulty emptying the bladder or bowels. During his presentation, Dr. Barenberg will discuss diagnoses and treatment options while answering all of the questions you don't like to talk about. So with that, I'm just going to go ahead and let him get started. We'll give him a second to share his screen and we'll get going.
All right, let's see. Can you see that? Are we good?
Yes.
All right. So I'm going to keep this pretty casual. So if you want to pop in and say, hey, stop, I have a question about that, that's fine. But we're just going to kind of get into it. My goal today is just to give you a general overview of urogynecology and who we are, what we do, what we treat, and then to field any burning questions that you guys have. I work out of Optimal Health Associates. It's at 9800 Broadway Extension in Community Hospital. We're on the 2nd floor there. And I operate out of there, Integris and Northwest Surgical Hospital on Britton and May. So we're going to define urogyn. We're going to talk about general anatomy, very general anatomy of the female pelvis and pelvic floor. We're gonna talk about pelvic organ prolapse, what that looks like, things that we can do commonly to fix those things. We're going to talk about urinary incontinence, the most common types of urinary incontinence and how we manage those. And then I was going to touch on some of the other services that we have at Optimal Health that may be of interest, and then a chance for some questions and answers. So what is a urogynecologist, otherwise known as I haven't figured out how to put this, but the title is Female Pelvic Medicine and Reconstructive Surgery. But like many other medical specialties, you can't say like female pelvic medicine and reconstructive surgeonologist. It just doesn't work very well. So they switched it and they call it urogynecologist. And so we are kind of the experts in surgical and medical management of pelvic floor disorders. So as mentioned prior, that's urinary and fecal incontinence, pelvic organ prolapse, where the pelvic organs descend through the vaginal canal and sometimes even out of the vaginal canal, issues with the lower urinary tract. So it's everything from recurrent UTIs to blood in the urine to people who've had stents that they need to have put in and taken out. What else? Diverticulum, where you get these little kind of ballooning outpouchings of the bladder or the urethra that can cause infections and need to be closed. Bladder injuries from deliveries. They call me in if they injure the bladder on a C-section or something like that. And then complex gynecology is another big piece of my practice. So we do a lot of fibroid surgeries, endometriosis, which is a complex pain condition. We also treat pelvic floor pain, or what they call levator spasm, where you get a lot of high tone contractions, or the pelvic floor kind of tenses up and starts to cause pain as it essentially chokes out the nerves, similar to how if you were to get a neck spasm or a back spasm. And that's a big piece of what I do with those patients. It's critical. The silver bullet there for them is pelvic floor physical therapy. So I'm a complete proponent for them. I think that they do amazing work. So, all right. So general female anatomy. This is if we cut you in half kind of this way. You can see at the front, towards the left would be the patient's abdominal wall, and then towards the right would be their back. And kind of halfway down in the middle, you'll see the pubic symphysis. So that's the pubic bone right there in the middle. If you feel on yourself, you can feel it right there at the top of the pelvis. And then directly behind that, the bladder lives there, and you can see the urethra tube that's coming to the outside world there. The vaginal canal, and then the uterus is sitting at the top of the vaginal canal, and then way in the background, there's an ovary and fallopian tube floating over there. And then posterior part, or the posterior compartment of the vagina, includes the rectum and the anus, which you see on the right side of the screen below the right-sided vaginal wall, or the posterior vaginal wall. So that's just the generalities of the organs we're talking about. So long and short of it: bladder, uterus, vagina, ovaries, rectum. And the next piece is the bony structures of the pelvis here. This is just to give you an idea, looking down into the pelvis. You have the iliac crest on the sides there, they kind of look like wings. We have lower back involvement in the SI joint, or the sacroiliac joint. And then we have the pubic symphysis on the front. And then underneath all of that muscle, there are other bony prominences like the tailbone, the ischial tuberosities, which there's some ligaments there that we use for suspension procedures. You can't really see them here, but there's a lot of bony structure involved in the pelvis. And then on top of that are the muscles. So we've got bones, we've got the organs that are sitting there, they're supposed to stay in the right spot. And then we've got the muscles that are there to support that. And not to belabor this, but as you can see, these are painted a little bit different color, and that's kind of a nice breakout of all the different muscles that are involved in pelvic floor control. So the key to take away, though, is you can see that, like, look at the yellow band there. If you start on the left side, it starts on the back of the pubic symphysis, or the bone, and then it sweeps down around that where it says U and V, that stands for urethra, vagina, and then at the bottom where it says EAS, and then there, it looks like there's a cylinder, that's the anus. And so you can see that those muscles swing down around the urethra and the vagina and back up and reinsert on the other side. And then if you go a little bit lower, there's another yellow band that goes just outside of the first one, and that sweeps down and around the rectum and back up to the pubic symphysis. The long and short of it are, if these muscles start to spasm, it can interfere with your ability to urinate, your ability to hold urine, your ability to have urgency and frequency. What else? Vaginal pain during intercourse due to muscle spasms as they wrap around the vaginal canal. And then around the anus, if those muscles don't relax well, it can make it very difficult to have bowel movements, or if those muscles have weakened, it can make it to where you can't hold your stool in. So talked about the muscles. And then the last piece of all of this is the connective tissue. And this is a picture, again, looking down into the pelvis, like if we were standing at the patient's head. And in the back, like towards the bottom of the screen, you see the rectum. And then about halfway up, you see the uterus sitting there with the connective tissue, the white stuff kind of wrapping around the uterus there. And then the bladder at the top. And then it shows all these potential spaces and how the connective tissue kind of helps keep the orientation between each of these organs so that they stay in their right spot. So another way to look at this is, it's called the boat analogy of pelvic floor biomechanics. So if you think of the boat as being the pelvic organs, rectum, uterus, bladder, vaginal vault, and then you think the ropes that are holding the boat to the dock as that connective tissue, and then the water is the pelvic floor muscle that's kind of holding everything and supporting everything. If you have a defect in any of these things, you end up with that picture on the bottom. Everything kind of comes crashing down. So that's what we're working on addressing. So first, we're going to talk about pelvic organ prolapse. About 24% of women in the US have pelvic floor dysfunction that is symptomatic. So about 1 in 4, and almost half of women have some level of pelvic organ prolapse. So even women who haven't had children. It's not always problematic. With pelvic organ prolapse, I don't worry about it until my patients worry about it. If it doesn't bother you, no big deal. But if you're starting to notice pressure in the vagina, or you're feeling like you're sitting on something, if it bothers you, it bothers me, we'll fix it. So there's a couple of different types or general types of pelvic organ prolapse. So this first one is called a cystocele, or we also call it anterior vaginal wall prolapse. And the long and short of it is, this is another one of those cut sections like this. You see the pubic symphysis, and then where it says vessie, I guess this is maybe a French slide or something that I found on Google. But you can see that it stands for the bladder, and the bladder is dropping out of the vaginal tube and rolling towards the opening. So that's called a cystocele. That in and of itself can lead to urge and frequency. It can lead to urinary incontinence, can lead to that feeling of pressure and bulge in the vagina. People will leak during intercourse if their partner, hits the bladder in a certain way. So it can be pretty problematic. And for some people, it doesn't bother them at all. So that's the anterior vaginal wall prolapse. And then we can flip that over and talk about what's called a rectocele, which is a posterior vaginal wall prolapse. So again, we cut you in half this way. The pubic symphysis is there, the bladder, the same orientation. And instead of the bladder dropping, this time we have the rectum bulging in to the vaginal canal and out towards the opening. And the key here to remember is there's nothing wrong with the bladder, and there's nothing wrong with the rectum, but there's everything wrong with the fascial layer or the connective tissue that's meant to support the front and the back wall of the vagina. And that's what we're addressing. So a lot of times when we get these things back in place, people's bowel issues improve. So people with chronic constipation, as you can imagine, if you push and push and push and push and push to get stool out, how that would stress out the back wall of the vagina, and you start to get that kind of bulging picture. So usually in a lot of women, the constipation can lead to large rectoceles. And then the question I get when I come in is, hey doc, I feel like it gets stuck. That the stool gets, like a big stool ball gets stuck right before it's supposed to come out. And as you can imagine, in that little pouch there, like right here, that's exactly what's happening. The stool comes down, it gets stuck, and then it can't get it down through the anus. So when you reduce this, now you have a straight shot and you're able to empty a little bit better. And then the last piece, we talk about front wall, back wall, and then we want to talk about the third compartment, which we say is the apex or the top. And that could be the uterus, if you still have one, or it could be the top of the vagina where the uterus used to be if you've been post-hysterectomy. And as you can see, these are pretty dramatic. It has the uterus kind of hanging all the way out. We do see that frequently. And then the second one here, you can see there's a loop of bowel, since there's no uterus to kind of keep it out of the way, that gets incorporated into that everted vagina. So it's as if you take a sock and you flip it inside out, and then everything that was inside is now funneling down the sock, and so we have to correct that. The same deal. A lot of times this is an issue with the support structures. So anchoring the cervix, there are ligaments there that are supposed to keep it taut against the deep pelvic bones to help support things. And then there's a whole layer of fascial tissue or endopelvic fascia that goes to the lateral side walls to kind of keep things in the right orientation. And then there's even support structures for the little ovaries up at the top as well. If you have babies, the most common cause of pelvic organ prolapse is vaginal delivery, stretching the muscles, stretching the ligaments. As you can imagine, pushing a baby out of the vagina can stretch those ligaments, and then you may end up with something like the C, or uterine prolapse there. So what do we do about it? First is, you don't have to do anything. It doesn't bother you much, or it doesn't bother you at all. The chance of it worsening over time is about 20% a year. The second option would be a pessary device. And on the left here, in that kind of picture that's set in the back, there's a million different kinds of pessaries. There's rings with support to kind of hold the uterus up. There's rings that have a diaphragm in the middle that are supposed to help support things a little bit differently. The one in the bottom right corner has a little knob on it that's supposed to help with urine leakage, as you imagine it's pushing on the urethra like so. And then you have on the top left, there's one, it's called a Gellhorn. It looks like an upside down ice cream cone. That one I tend to reserve for more complex prolapse where they can't retain a ring pessary, or the opening, what we call the genital hiatus, is too wide that one of those simple rings would fall right out. That Gellhorn pessary will actually suction to the top of the vagina or the cervix to keep it in place and to hold things. And then the one at the top looks like a donut. That's what it's called, a donut pessary. And then there's a cube. And the point of the cube is that for people who have vaginal vault prolapse, where they've had a hysterectomy, but everything's just kind of caving in like this, each little circle on that cube creates a little suction on one of the walls of the vagina to keep it in the right orientation. The bottom right picture, you can see kind of how they're put in. We place them in the clinic. We size you first. Make sure that it's comfortable, have you get up, move around. I make people jump up and down. I make them squat and push to see if it falls out. And then we have them use the restroom to make sure that they can empty their bladder appropriately. And as long as it's comfortable, then we've got your size, and then we can order that pessary for you, teach you how to put it in and take it out or manage it. Or for some of our older patients that don't have the hand dexterity to do that, we set them up to where they come in every 3 months. We take the pessary out. We make sure the tissue looks healthy, that there's no abrasions or little ulcers from rubbing. And if all's good there, we pop it back in and keep moving. And so the general idea carries across from left to right. There's just different types of pessaries. And then one of the things I didn't include here, but some people will do physical therapy for prolapse symptom management. It doesn't always get things to go back where they need to be, but it gets rid of that pressure and some of the urgency frequency that people could have, and some of the bowel issues that they could have from their prolapse. So for those who are having, hey, the bulge doesn't bother me, but the functional side of that is bothering me, then physical therapy is a great option. So this is a picture of a cystocele again, which is the bladder kind of dropping into the vaginal canal. And there are a type of repair that we do that would be just a vaginal approach. It's an outpatient surgery. Takes about 20 to 30 minutes to do this. It's called a site-specific repair. So if you look in the middle picture here, you can see we made an incision through the vaginal epithelium or skin, and then we dissect down until we get to this white tissue. This is the fascia, or the connective tissue, that's supposed to keep the compartments separate. And as you see, this little pink band in the middle of the white, there was a tear in that fascia. So as you imagine, you know, if my hands are the fascia and then you have a hole in it, anything that it's supposed to be supporting will now drop through the hole. And that's why we end up with bladder prolapse. And then the flip side of that is that's why we also have rectum prolapse or rectocele. And so we reapproximate those edges with a suture that dissolves, and then we trim the stretched out skin and we close that up, as you can see on that far right little graphic. So that would be a very simple way to correct an isolated anterior vaginal wall prolapse. Many times these things come in bunches. So if the uterus is falling, the bladder's falling, and the rectum's falling. If the uterus is staying where it needs to be, and we just have a failure of the bladder or the rectum, then that's fine. We just address each compartment. If you ignore any of the compartments, the success rates of the repairs are much lower. And this is the flip side, same idea. We have a tear in the fascia over the rectum, and you can see we make that same type of incision, find the tear in the fascia, recreate the tissue there, and then trim the redundant vaginal tissue and close that with an absorbable suture. These kind of repairs are all outpatient. And then the more complex repair would be for somebody who has uterine prolapse or vaginal vault prolapse where the top of the vagina is coming down. So if you imagine when you put your pants on, if you don't button the top, the legs fall. So the anterior and the posterior vaginal wall would be the legs of the pants. So if you put the pants on and you buckle your belt, the legs stay in the right spot. So after you fix the front and the back wall, we need to make sure we're addressing the top so that the pants don't fall again. And if you look closely, there's a little shadow there where a uterus used to be. So many times this involves a hysterectomy, but we tend to leave the cervix in place. The reason we do that is that gives us really tough tissue to stitch into that will hold suture. And then we dissect the bladder and the rectum off of the vaginal tube here, and we drape a surgical grade polypropylene mesh over the front and the back of the vagina. And then we pull that up to a ligament that actually runs over the top of your tailbone called the anterior longitudinal ligament in the sacrum. And we anchor those in place there. This is a little bit of a misnomer. It looks like we're anchoring it in a disc, and I think that would cause a ton of pain if that's actually how it happened. But it's very superficial to that. Everyone kind of freaks out about the mesh stuff with all the litigation, the news it's gotten over the past, 10 years or so. The key to know here is that in 2009, the FDA put a warning on pelvic organ prolapse mesh, both placed abdominally, vaginally, and used for urinary incontinence. They spent 2 years, 2009 to 2011, pulling all of the data surrounding these types of surgeries. And they came back and they said, this procedure, since it's been very well studied, the complication rates are low, 1 to 3%. Mesh usually doesn't cause any issues. Have a risk-benefit analysis with your patient. If they feel like it's appropriate for them, you're okay to move forward with abdominal place mesh. And the reason why it has less issues is because you get the full thickness of the vagina versus the mesh kits that were pulled off the market, where a surgeon would be trying to correct the same things from a total vaginal approach. This is done with the laparoscope, but they would try with a total vaginal approach, make a large incision on the front of the back wall of the vagina, lay a big sheet of mesh down, anchor that to some ligaments, and then close that over. That procedure had a complication rates of up to 20%. A lot of times it caused pain, scarring. The mesh, since it's a split thickness for how you place it, you don't get that full thickness of the vaginal tissue. There's a higher risk for that to erode and have mesh in the vagina and bleeding and pain. So I don't do those procedures, vaginally placed mesh. If we need to do something apical, my go-to would be a sacrocolpopexy. For people that are mesh averse and they don't really want to do that, there are some ligaments that we can use with just a general suture to the back of the cervix here as well, and not use the mesh, but we lose some efficacy. So the success rates of this procedure are about 90%. If we take the mesh away, the success rates are about 75, 80%. And the reason that is because the mesh actually stress shields the vaginal vault. So it's similar to The backing on needlepoint. So for people who sew, I've never done it, but from what I've seen my grandmother do, on the back of the needlepoint, you stitch into that because it spreads out the pressure so that you don't get a hole through whatever you're stitching. Same deal. When you stitch into that vaginal vault and anchor the mesh down, if it pulls in one spot, it's spread out over the entire mesh, versus if I just did a bunch of sutures, if it pulls in that spot, it has a higher likelihood of pulling out. All right. And so now we'll talk on generalities on urinary incontinence. 16% of women have bothersome urinary incontinence. So that's still a pretty substantial number. And there are multiple types. So this is a nice little graphic. There's stress incontinence. So if we look at the far left, we have the little bladder, and this is supposed to be the opening of the urethra. There's a sphincter here, or a muscle, kind of like the knot on a balloon, that when you cough or sneeze, it's supposed to squeeze down to prevent you from leaking. Over time, that muscle weakens the same way that many other muscles in our bodies weaken. And we lose the ability to actually hold that urine in when we exercise, cough, sneeze, jump, lift. And so we'll get into the therapies for stress incontinence here in a moment. And then, oh, it looks like we got some questions.
No.
Okay. Yeah, shoot them up there. I just pulled a little thing up in the corner, but shoot them up there if you have them. And then the second type of incontinence is called urgency incontinence. So that's the second one from the left. And the key here is that it's not an issue of the sphincter muscle or the holdback muscle. It's an issue of the nerves that are innervating the bladder. So they get really excited and they just start to quiver like this. You can't control them, and you get random leaking throughout the day. A lot of times it's a developed pattern. So I see it a lot in teachers. I see it a lot in nurses, people that don't have the ability when they need to go to the restroom to just go. They just tough it out or hold, and they develop this voiding pattern to where finally the bladder's like, you need to go. And then that becomes more and more frequent. And then mixed incontinence is a mixture of the two. So the sphincter isn't working well, and you're having the overactive bladder component. And with that, the key is to just focus on the one that bothers you the most first, get that under control, and then work our way back to the other side. And the last one would be what's called overflow incontinence. That's a little bit more complex. I have a short slide on that a little bit later. But the key there is that the bladder doesn't empty. So it fills up. It's like carrying a cup of water and just sloshing it around after you filled it up. It's just spilling out over the side. You just have no control because you have inability to empty your bladder. Let's see. Were there any questions? Not yet. All right. Oops. Okay, so general evaluation for urinary incontinence, obviously come in, we talk about it, get a general idea of what you're experiencing. Many times we'll do some bladder testing called urodynamics, and this is a computer printout. The long and short of it is we put a very small catheter in the bladder, a very small catheter in the vagina. We refill your bladder. We fill your bladder through the little catheter. At certain points, volumes, we have you cough to see if we can produce that stress incontinence leak. And then the little catheter in the bladder has a pressure transducer on it. So if you start to get those abnormal bladder contractions, it'll pick up the little waves on there and I can see them. The other key is it also lets me know what the pressures are in your bladder. So it gives me an idea if your kidneys are at risk. And it also tells me a little bit of how you empty. So the last part of this test is we have you sit on, I call it a robo toilet, but you sit on the toilet, we step out void with the catheter in, and it shows us what's happening with the sphincter muscle and your flow. The goal here is to reproduce whatever issue we're trying to treat, whether that be stress incontinence, urge incontinence, incomplete bladder emptying, just to give a better qualification of what's going on so we can tailor therapy to that patient. So we'll talk a little bit about management for stress incontinence. I really feel like pelvic floor physical therapy really shines here, especially if it's a mild to moderate stress urinary incontinence. The goal here is to rehab that sphincter muscle. And so as you can imagine, just like going to the gym and lifting weights, they will be able to work certain motions with certain rep ranges to strengthen those muscles to help you get a little bit more control. Maximum benefit can be a bit delayed, just like any other training program. It takes time for your body to respond and adapt to the stress that you put it on. So when you're doing those exercises, you're asking your body to do something that it has kind of lost the ability to do. And so you're retraining it. And that takes time to rebuild the brain and body pathways to get enough self-awareness to see, okay, if I squeeze this, now I know I'm squeezing the right spot. And that's what the physical therapist will do. They'll find the muscle that you need to be squeezing, essentially, and then help you locate it and then tell you, yes, you are now squeezing that muscle, you're doing it right. Success rates are up to 75%. I think they could even be higher than that in some populations. And the key here is guided therapy. So I have a lot of patients that come in and say, well, I went on YouTube and I pulled up a video on Kegels, and I do Kegels every day. And it was useless. It didn't do anything, and I don't want to go to physical therapy because I've already done it. Wrong. Most people, they can't identify the muscle that they're supposed to be Kegling to begin with. So they have very low success in drying up. And that's because a lot of people, as you lose control of your pelvic floor or it atrophies, we start calling on other muscles, thigh muscles, our glutes, lower abdominal muscles to try to make up for that lack. And so that's where the physical therapist is going to really focus in on teaching you to contract the muscles you're supposed to be contracting and relaxing the ones that are pulling the weight for now. Second touch is Mona Lisa vaginal therapy. This is a little bit more out of the box. So we're pretty aggressive in our office with regards to more progressive therapies like certain stem cell therapies and laser therapies for pelvic floor disorders. And so the Mona Lisa vaginal laser is a CO2 laser that we use to treat stress incontinence. And the key here is that this one actually helps regenerate collagen. So we would really focus around the periurethral tissue. You can see the little probe in the vagina there and how it's pointed up towards the bladder. And so we would treat the base of the bladder back and forth to try to regenerate that collagen so that it pulls the urethra just a little bit tighter, supporting that sphincter muscle that's leaking. It works best for mild stress urinary incontinence. For people who have a lot of leaking, I steer them away from this. It's an office procedure. It's usually 3 to 5 treatments. They take about 5 minutes to do. There's no downtime. We numb the outside of the vagina with a little bit of numbing cream. Do the treatment. We tell you don't have intercourse for the 2 days before, 2 days after. But other than that, you can pretty much do whatever you want. And success rates are pretty good. So 50% improvement in quality of life, 60% improvement in leak weights. So there's a small study out of Europe where they actually had women do their exercises or whatever made them leak while wearing a pad. They measured the pad weight before Mona Lisa, and they measured the pad weight after having treatments, and they saw a 60% improvement, which is pretty good for a non-surgical approach. So, okay, so I got a couple of questions. I'll field them real fast because these are pretty pertinent to the PT stuff. Do Kegel exercises help prevent urinary incontinence? Yes and no. For certain people. So if you have stress incontinence and you can Kegel appropriately, yes. Again, we got to make sure we're pulling on the right muscles. If you have urgency incontinence, which we'll get to here in a minute, Kegels can actually make that worse. So if you got to go, and you can't get there fast enough, potentially doing more and more Kegels, trying to regain that control, is going to actually work against you, because most of the time in that scenario, the muscles are too tight, and that irritates the bladder and causes it to start to quiver. So the key with physical therapy in those patients is to teach you how to relax those muscles so that they're not irritating the bladder. And then what weakens the pelvic floor muscles more? So it's multifactorial. The biggest hit that a woman takes throughout her life that it can interrupt pelvic floor muscle is childbirth. And so that's the big one. But a majority of the time, women will recover a majority of what they lost immediately after childbirth. So, you'll be going along and say this is your pelvic floor muscle strength, childbirth, boom, it drops off, and then you recover, but you never quite make it back up to that first level. keep going along, have another baby, childbirth, come back up, you don't recover. And then over time, we start aging. And with age, muscle mass drops. And so now we've got the inability to completely recover and more weak muscles from being older. And then certain activities like chronic constipation, anything that causes you to chronically bear down in your abdomen will put stress on the pelvic floor and your bladder and potentially lead to that. So it's a little bit of everything, but if I had to pick the one thing that I see most commonly leading to this is childbirth. Although I have seen stress incontinence and pelvic floor dysfunction in nuns that have never had kids and have never had intercourse. So it's not all encompassing. There is a genetic component. For instance, if you had a connective tissue disorder like Ehlers-Danlos, where that connective tissue is really mobile and flexible, it's not going to hold the bladder in the right orientation quite in the same way. So in those patients, they could be 19, 20, or even high school, and they start having stress incontinence during athletics and sports and things like that. All right. So we hit those. So another treatment for stress incontinence. Oh, what did I say? Yeah. So we got the improvement scores here. The next more common treatment is called urethral bulking. So I like to kind of make the analogy to facial fillers for aesthetics. We use a cystoscope, which is like a small skinny camera that we can place through the urethra. We drive that up right to about where the bladder and the urethra meet. And then we inject that filler material, if you think of it as a clock face, at the 3, 6, and 9 position, so that if this is the outflow tract to start, after you fill it up with the bleb, as you can see in that small photo, the outflow tract shrinks. So now that muscle doesn't have to work as hard to contract down and keep you from leaking. Great improvement, 75%, about half of those people will be completely continent. The downside of this is it's not permanent. It'll wear off in, on average, about 2 years. All right. And the most common thing we do for stress incontinence, and people have probably heard about this, is called a mid-urethral sling. So this is another application of mesh. It's the same material we use to resuspend the vagina, but in this case, we're using it to support the urethral sphincter. And essentially, the long and short of it is it's partly obstructive, and it creates a speed bump so that when you're exercising, if you jump and it pushes down on your sling, it's going to be very hard for your bladder to leak over the top of that crook in the urethra. And then when it's time to void, you're supposed to relax your pelvic floor muscles. The bladder is supposed to elevate over the top of the sling, and then you're able to empty completely. So there's a couple different types of slings. The two most common, and the two that I do, there's one called a retropubic mid-urethral sling on the left. You can see the little mesh tape underneath the urethra, and then it goes back behind the pubic bone and exits the anterior abdominal wall or the skin, and then we trim that back. To place that takes about 15 minutes, outpatient surgery. Recovery time, with mesh procedures, I tell people 6 weeks, no heavy lifting, no intercourse. The key is we want your body to grow into the mesh, infuse that in place, because if it slips too far forward, it may be hard to empty. If it slips too far back, it's not going to work. You're still going to have leaking. And then a mini sling is kind of a different type of play on this, but it anchors in a different spot and it has a much less mesh involved. So you can see these anchor, they call this the obturator membrane, or the obturator muscles here. And so we dissect over in the same manner that we, same place we put it here, dissect over and anchor it on both sides there. And then we can tension it depending on once we fill your bladder, if you're still leaking. The difference between that one is if I have athletes, I do a retropubic sling, because as you can imagine, this is inserting into muscle. So if you're a runner or a weightlifter or something like that, and it's pulling on those groin muscles and the muscles that are involved with movement of the hips, that could be quite painful. For some people, it's not common, but for some people that can cause pain. So if you're athlete, I stay away from the mini sling type deals, and I do a retropubic sling. If you're not an athlete, if it's an older patient, or I'm worried about the mesh burden in certain people, then a mini sling is a great option there as well. Or if the leaking isn't real dramatic, say you have relatively good control of the urethral sphincter still, but if there's certain scenarios, it only happens when I do crunches or something like that. A lot of times a mini sling will help with that as well. And then kind of the more old-fashioned treatments that we don't do as often anymore, one called a rectus fascia sling. And so that one, we actually make like a C-section incision, and then we harden connective tissue from the lower abdomen, fashion a sling out of that with permanent sutures, and then pass that back up through the vagina here and out the anterior abdominal wall, similar to the retropubic type. And then we anchor that to the fascia and close the fascia, close the skin. Success rates are great, 90%. It's about the same as a mesh sling. So a lot of people say, why would I do a mesh and insert a foreign body when I can use my own tissue? And there's a very simple answer to that. If you have a rectus fascia sling, a lot of times you also have to place what's called a suprapubic tube, which is prevents you from going into urinary retention after surgery. So the retention rates, meaning you can't void, are much higher with this rectus fascia sling. So we actually pass a catheter through your abdominal wall between the belly button and the pubic bone directly into the bladder so that you can empty while you're healing. And the hospital stay is much longer, whereas a general mesh sling, you're in the OR for about 15 minutes, 20 minutes, and then you go home directly from the recovery room. With this procedure, you're going to stay in the hospital for 1 to 3 days while your abdominal incision is healing, making sure your pain is controlled, making sure that your bladder is functioning in a good way, and then we make a decision as to when to pull out that drainage tube. And then the last one, which we do a few of these here and there, it's called a Birch urethropexy. And this is usually I would say, fourth line for people with bothersome stress incontinence after I would do a sling or bulking or physical therapy. This is essentially, you do the same kind of C-section scar. So we dissect down, we drop the bladder off the back of the pelvic bone. So here's the pelvic bone, here's the bladder. Usually it's stuck here. So we dissect that down, push it out of the way. And then we put permanent sutures on either side of the urethra. And this one is higher up at the bladder neck. And we anchor that to what's called Cooper's ligament, which essentially is a tough ligament that runs right across the back of the bone. Works well. Dr. Williams and I, my partner, we do these together. It's kind of not many people are doing them anymore, and that's what he was trained on, and we did very few in fellowship. So it's kind of nice to have somebody with an extra set of eyes that can help me with these if need be. The downside here, recovery time. You have to make a bigger abdominal incision. You stay the night in the hospital versus going home the same day, and the success rates aren't quite as high as a mesh sling. So we'll talk about urgency. First line, adjust your behaviors, decrease your fluids by about 25% if you can. Pelvic floor physical therapy, which we had mentioned before. And then for a lot of people, if you're able to lose a little bit of weight, if you're on the obese side or overweight side, 10% drop in body weight will improve your bladder symptoms by up to 40%. So that's another onus for people to, hey, let's go get healthy. Let's get our nutrition right. Let's start to exercise, do some sort of walking, movement, whatever it is to get the weight to start shedding, because your bladder function will follow that. It doesn't have all that pressure from the extra weight people are carrying. And then the second line therapy would be medication managements. There's general 2 classes of medications that we try. First class are called anticholinergics. The goal and the second one's called a beta-3 agonist. The goal for these medications is to just calm those nerves down that are quivering. They do have side effects for some people. The one class of medication, the side effects, if you have uncontrolled blood pressure, it can spike your blood pressure. So I always tell those people, about 1 in 10 people that happens to. If you start to get headaches or vision changes, check your blood pressure. If it's high, it's the medication, stop it, let me know. The other class, you probably know about these, would be like Ditropan, Toviaz, oxybutynin, Detrol. Is an older class of medication. Side effects there is it dries you out. So dry eyes, dry mouth, constipation are the big ones that we see. And so depending on your patient's comorbidities may help you pick one versus the other. If I have somebody, that has chronic dry eyes and dry mouth, picking an anticholinergic just doesn't make sense. Most of these are daily dosing. Some of them, they have an immediate release formulation that say people will use. They do well when they're at home and have access to a bathroom, but as they travel or they're driving in the car, it becomes a little bit more difficult. So they'll take a shorter acting version of those medications to help control during travel or sporting events or whatever. And these can help improve both how many voids you're having a day and how many urge leaks that you're having. And then we get into the third line therapies. So the first of the third line therapies would be called posterior tibial nerve stimulation. So I think this is like a revved up version of acupuncture. So he has her leg kind of propped up, and then down in her ankle, this is the tibial nerve that runs from the same nerve root in your back as the bladder's nerve, runs all the way down the leg towards the ankle and the foot. And so we can tap into that nerve with an acupuncture needle and then stimulate it with essentially a TENS unit. And that TENS unit sends a signal up the nerve, and it modulates the signal that your bladder sends to the brain. So it works as a resistor. It prevents some of those signals from traveling up. And as you can imagine, if you're getting an overflow of bladder signal that's causing you to have urgency and frequency, by blocking that, that starts to resolve. It takes time. You do one treatment a week for 12 weeks. It's done in the office. It takes about 30 minutes to do that. There's no downtime once you leave because there's no cutting, there's no implants, anything of that nature. And it takes a while to work. So most people will start to notice an effect from anywhere from the 6th to the 8th treatment. And then once you get to that 12th treatment, there you have to do boosters. So once a month to once every 4 to 6 weeks, you come in and you do a booster just to keep that signal blocked. And it has up to 80% improvement. And then this is almost the same thing as the posterior tibial nerve stim, but a little bit more direct. So I call it a bladder pacemaker. And if you look at the photo, you see there's a little battery pack that's implanted under the skin in the hip. And then there's an electrode that runs down to that nerve root that feeds the bladder, and you get a constant stimulation to help block that signal to the brain. I like this procedure for 2 reasons. One is it's a 2-part process in getting it going. So there's a test phase, like a test drive essentially, where the patient comes in the office. We place the lead down by the nerve that feeds the bladder. We tape that in place on their skin, and we use an external battery pack to let them see the results that they could expect during having an implant. So they wear that around for about 2 days. They keep a bladder diary, and they come back in, and I don't have to tell them that if it worked or not. They tell me if it worked or not. So it's a completely in the patient's wheelhouse as to what the next step is after they've done the InterStim test. If they decide, yeah, this was great, I want to move forward, then I put them under anesthesia. We make a little incision over the hip bone, drop the battery in, tunnel across, put the lead in, stitch all that up. That takes about 30 minutes to do, outpatient procedure, and out they go. They do have control over the device. It comes with the Samsung Galaxy phone, and it allows you to change the pattern of stimulation. So you can imagine there's 8 programs on there. So you can switch the channel on the device, and you can increase the volume. And then there's another little segment on there for the practitioner where they can adjust the wavelength and the amplitudes, and then some more complex electrode settings on there. And the success rates there are pretty good, 80 to 85% improvement, with almost half of those people being completely dry. So are there any early signs of a decrease in the pelvic floor, such as a feeling of something coming out while coughing or sneezing? Yes. So early signs of prolapse would be feelings of pressure, feelings of bulge. Some people say it feels like they're sitting on a ball or a piece of fruit, or during intercourse, it feels like my partner's hitting something. A lot of times I will hear, I was in the shower and I was washing up, and when I felt down there, I kind of felt something at the opening, and it threw me off. I thought I had a tumor, and they come in, he say, no, it's prolapse. And sometimes with the functional stuff, like the urinary incontinence, you start to develop the symptoms of urinary incontinence, increased urgency and frequency, constantly running to the bathroom, starting to have a little bit of dribble with exercise, or even immediately after childbirth. I mean, I encourage people to go see a physical therapist or see a urogynecologist immediately after childbirth, within the 4 to 6 week window after you healed up pretty well. Assess the pelvic floor muscles, and then that way we can get them over to the physical therapist if they need it, and then they'll rehab everything else up. You would do that for knee surgery, you do it for back surgery. Why aren't we doing it for birth deliveries, which is, I would argue, much more traumatic than having a knee replacement? Yeah, good question. All right, and then this is one that everyone always hopes that there's a little bit extra in the vial, but we actually use Botox in the bladder muscle to help with urgency incontinence. So we snake a little camera in through the urethra. I sedate people for this procedure. It's kind of like having a colonoscopy. It's very quick. But as you can imagine, passing a cannula through the urethra and then having a needle that injects into your bladder can be pretty uncomfortable. But we actually pass the camera in so we can see the bladder wall, and then we pass the needle through the operative channel, and we can inject Botox in all the way across the dome of the bladder. Then that partially paralyzes that muscle. Upside here is that there's no downtime again. Downside here is not permanent. It lasts on average 9 to 12 months. And in certain populations, they end up having higher rates of urinary retention depending on how much Botox we use. On average, most people, it's about 5%. If you fall into that 5% and you can't void afterwards because the bladder is too sensitive to the Botox, the patients need to understand ahead of time that there's a possibility they will need to be able to do an in and out cath, or pass the catheter, drain their bladder, and pitch it in the trash a couple of times a day for usually a couple of weeks. And you can see success rates here are still pretty good. Everything is in the realm of 65 to 80% success for urgency incontinence, and about half of those people are cured. So the discussion really becomes which of these makes the most sense for you and your lifestyle. If coming in and having a bladder treatment on your ankle makes sense because there's no cutting and everything else, by all means, even if it takes up a little bit more of your time, and etc. And then there's mixed incontinence, where you have both the stress component and the urge component. The key is to focus in on what's the most bothersome symptom for the patient. So a lot of times it's the urge incontinence, unless they have really florid stress incontinence. In case, we try to get the urge incontinence optimized, and then we address the stress incontinence. If you do it the other way, sometimes the treatments we use for stress incontinence can actually temporarily worsen urge and urgency incontinence because of the irritation that happens around the bladder neck and the urethra. So it just takes kind of a combination of the two, and some shared decision making with the patient and physical therapist to make sure that all of these things are working towards the patient's goal of decreasing the bother. And then overflow incontinence. So as I mentioned before, this is much more complex. The first question to ask is why, and that could be everything from nervous system disorders, so things we see like multiple sclerosis, that's the big one that we see. You have a younger woman come in and say, hey, I can't pee sometimes, and other times I have really bad urge and I'm leaking, and then other times when I cough or sneeze, I leak, and oh, by the way, I fall a lot, but I don't know what that's about, and I get dizzy, or my balance seems off. And so those people, you need to look for MS and send them for a MRI of the brain to see if you see anything there. Diabetes, the same way that it can affect other nerves, peripheral neuropathy in the feet, where people get tingling. The nerves that feed the bladder are exactly the same. But when that sugar attacks the nerve over a long period, usually it starts to show up around the 10-year mark. If it's uncontrolled, patients will develop a real big floppy bladder that loses its ability to contract, and it just fills up with urine and sits there. And then, like we mentioned before, we go running around during our day, and that sloshes our bladder around. We just get constant leak. And then there's the trauma side of things, brain and spinal injuries, traumatic brain injury. And in these people, It can do all of the above. It can affect your muscles ability. It can affect your bladder nerve ability. It can make it to where you can't empty. It can make it to where you can't hold it. And so we want to make sure we're focusing in on that and addressing that as well. And then obviously muscle spasm. So if the muscle that goes from the pubic bone around the urethra and back up won't relax because you're carrying so much tension in there, there's no way you're going to pee over the top of that muscle. So it's going to make it very difficult to empty. And therapies to address this, first and foremost, pelvic floor therapy. There are certain medications that we can use in a very narrow window where another condition with incomplete emptying is when the bladder contracts and the urethra contracts. They're supposed to be going opposite of each other, but then they lose that ability to communicate and they just do whatever they want. And so if the urethra is contracting when the bladder is contracting, obviously nothing's going to come out. And so we can focus medications like Flomax, which is primarily used in men for big prostates, to help relax the bladder neck so that the urine can flow freely. Very simple therapy if it's traumatic brain injury or they have diabetes and they don't want to do anything operative, is you can teach people how to catheterize, and they catheterize 2 or 3 times a day, empty their bladder and move on. And then, another option would be a bladder Botox, which you're saying, wait, they can't empty, so why would you hit them with a bladder Botox? So you hit them with a bladder Botox in order to relax the bladder further. So for instance, this would be primarily for a person maybe that has a brain or spine injury. In those situations, the bladder becomes very spastic, hard, and small. So as you can imagine, it fills up quickly and then you start leaking over the top. If you hit them with Botox, now those muscles relax, the bladder can fill more and and empty more appropriately sometimes. Sometimes you combine the bladder Botox with catheterization, get them a little bit more time between their urges by relaxing the bladder, but they have this inherent inability to empty their bladder, so then you have them pass the catheter to drain out. So currently I have a urinary incontinence initiative. My goal is to help 150 people manage their urinary incontinence by the end of the year. And we're doing that through patient and provider education about pelvic floor dysfunction. So it's part of the reason I'm here today. And currently we have about 25 people. COVID's really put a damper on everything, makes it, people are a little bit gun shy with regard to stepping out and having operative procedures or even going to a physician's office. It's starting to loosen up a little bit now that people are getting vaccinated. They're feeling a little bit more comfortable, willing to come in and willing to undergo surgery without that fear of contracting COVID. So this is our goal. If you know of people that this may be of help to, feel free to pass along my information. That would be fantastic. And at a minimum, if they don't want me to examine them, they just want to know, like, what the heck's going on with urinary incontinence? What's that look like? We just have a discussion like this and talk about the different types, and then they can decide if it's worth it to them that they want to do anything else. That's a good question. Have I seen any urinary or pelvic floor issues due to COVID? No. That one, I'm trying to think of how that would play out with the COVID to cause that. Majority of the issues that we see with COVID in younger people after they recovered are random thromboembolic events where they get blood clots or heart attacks or strokes. And then for the older population or people with comorbidities, usually it's the viral infectious phase and the lung injury that's a primary deal. Now, I mean, I guess you could potentially say if somebody, is obese and they took a lung hit and developed sleep apnea as part of that, sleep apnea can then lead to nighttime leaking while you sleep. So that's a stretch. I would say that it would be very rare for that to happen unless somebody had a stroke and it affected the area of the brain that controls your pelvic floor muscles, your bladder, your rectum, etc. So other things that we do, complex gynecology, urogynecology, that's surgical stuff, non-surgical stuff. So we're talking about endometriosis, fibroids, what else? Fistulas, where you get abnormal connections between the bladder and the vagina, either through birth injuries or surgical injuries or bad infections. not bladder infections, but like gland infections that are near the bladder, and it kind of grows in and breaks down the bladder wall, and then you end up with this canal and it just drains urine all day. And you can also get that from the bowel to the vaginal vault, and they call that a rectovaginal fistula. A lot of times that's from trauma or birth-related stuff as well. We do bioidentical hormone replacement therapy. There is, some biologic plausibility that can help women with pelvic floor dysfunction, as if you can activate the androgen receptors in the muscles, theoretically they will get better response to whatever therapies they're doing, as they can rehab that muscle a little bit easier. And we do this for both men and women. We provide well women care. Long and short of it is, if you're having pelvic floor dysfunction, we need to make sure first that there's not some other pathology that's causing your issues. Rule out, make sure PAP's up to date, make sure mammogram's up to date, because all of these cancers, bladder cancer, cervical cancer, uterine cancer, breast cancer, the treatments that come with that can affect the pelvic floor long term. We talked about Mona Lisa. We do some facial lasers and aesthetics. And then we really leverage nutraceuticals and CBD and cannabis in our office for the more naturopathic type patient. There are a lot of pelvic floor conditions that I do use more nutraceuticals for, high tone pelvic floors, people with pain, and the same with CBD and cannabis. They have very nice anti-inflammatory and muscle relaxation properties. And actually, there's a couple of studies. I want to say there's one out of Minneapolis where they looked at cannabis and overactive bladder, and they saw a decrease in urgency, frequency, and leak, which is pretty cool. So we have access to that stuff here in Oklahoma. We're one of the lucky states that does. And so you can always keep that in the back of your mind as a potential for somebody who's failing all the normal stuff. Somewhat related to PT, what would you recommend to maintain healthy pelvic floor strength in younger women? Activity, be active, move. I do think exercise is always a good thing. It'll keep your muscle tone healthy. Yoga is great too. Pilates, anything that will strengthen and lengthen. Will keep a nice balance. It'll keep your hip flexors loose and keep those from getting too tight, and your adductors and your abductors, keep all that stuff functioning in a biomechanical balance. So that's a key thing. And then the second, when we start to see it in younger women, it's usually after babies. So I've been stressing this to the general OBGYNs in the community, and a lot of times they're just so busy that they just kind of forget about it. But get an evaluation after your baby. Let's get that 4 to 6 weeks of healing, stop in, see a urogyn, and see where you're at, if you've recovered everything. And then even if you have, I still would tell people, why don't you go visit with a physical therapist? They will kind of talk to you about things you can do at home, even if you don't need acute therapy, every week for 12 weeks because you're doing okay. Say, okay, maybe do these exercises at home once a week or twice a week, just to maintain that, just like anything else. All right. Any other questions?
Yeah, I'm double checking the chat, but I don't see any additional questions yet.
Okay. I'm not seeing anything come through.
If anybody else has one more question, feel free to chime in. Okay.
Of note, I'll say this too. Occasionally, about once a year, I'll get a workers' comp case for prolapse, which I find really interesting. And usually the patient is trying to say, oh, I was lifting something heavy and then I felt a bulge, and they're looking for, I guess, to get the repairs paid for, whatever. And I think that there's sometimes some truth to that. If you're, chronically lifting at your job, that puts you at risk. Whether that was the inciting factor or not is hard to say, and I'll leave that up to the attorneys to argue. All I'll do is, say, yeah, that is definitely a risk factor. You lift heavy stuff at your job. It could have been involved. I've also had people I had one patient, let's see, a year ago or 2 years ago, who had a condition called reflex sympathetic dystrophy, or essentially, or sorry, reflex sympathetic dystrophy, which essentially you get a trauma to, like she had a car wreck. And then she developed this terrible pain that went from the vagina down her legs to the point where like she couldn't have sheets on her. She couldn't wear clothes. Like any stimulus would just be horribly painful. And so she came in because she was also having leaking issues that developed because those nerves were so inflamed that it made her pelvic floor muscles tight, and she had terrible spasm. And we ended up actually doing Botox into her pelvic floor muscles to force them to relax, to then help her get back in with physical therapy and the other parts of her healing. And then I think somebody else had a question.
Yeah, we have one more question.
What's the recovery time for the interstim placement? It's short. So the placement itself, literally the incision's about, 3 inches long. It's over the top of your hip. We're not cutting into the abdomen, so there's no real surgical, there's really not a lot of surgical risk other than bleeding. And we implant the little battery pack about an inch down, and we stitch all that closed under the skin. And then I tell people, your body's completely healed in 6 weeks. You may not have a lot of pain. You can drive, go up and down stairs, eat whatever, shower, no problem from day one. Driving, it depends on if you require pain meds. If you require pain meds, don't drive with being on narcotics. If you don't, and you're comfortable driving, sitting on your bottom, we don't put it in a spot to where the pressure of sitting in a chair should irritate it. And you can slam the brake and turn the wheel to get out of an accident, then you're more than welcome to drive. The big key here is, since that electrode that goes down to the bladder nerves that has these little like prongs on it that anchor it into the tissue near the nerve, if you're real aggressive with bending, twisting, or lifting too early, it can cause those to move. So we want your body to scar around those prongs to keep things from slipping. So that's be pretty much it. But the recovery is pretty easy. I've even done these with patients awake that had really bad comorbidities, diabetes. And, I had one patient whose BMI was probably over 40. And so putting her to sleep with anesthesia became a dicey scenario because of her ability to ventilate her lungs. And so we just did it under local anesthetic, and she did phenomenal. So, yes, it's surgery, but long and short of it is that it's a minor thing compared to other operations that we do. All right. Anyone else?
Well, very good. Looks like Diane Burden said very informative, and we just want to thank you so much for joining us tonight and presenting for us. It was super helpful. And also, I was going to tell you, if you have anything on your initiative to get to 125 patients, if you want to share that with us, we'll share it through all of our CMSA social media channels and share that across. So we would love to be able to do that. And then also for our attendees, just for you guys to know, share the word that this webinar was recorded, and we'll share it with share it through CMSA. And then I do believe Dr. Barenberg mentioned that he would be sharing it through his channels as well. So it will be out there for everybody to learn from. So yeah.
And
any final thoughts?
I'll get with Robert to get you guys some information on how to, reach out if you have somebody that would be, a good candidate for some of these things, or you think that would benefit just from the information. That way they can reach out to us. So I'll have him email that out, and I'll put together maybe a little graphic or something that can be shared.
That would be perfect. Well, very good. Well, again, we just thank you so much. We appreciate you jumping on with us this evening and spending some time with us to educate